We've had a great afternoon discussing real-world evidence and its use in the medical device and health technology total product life cycle. You've heard about NEST, our history. We've taken a deeper dive into a few of our pilot studies and even talked about lessons learned. We continue to complete our pilot studies, but we also have other studies we're also working on. NEST continues to develop our capabilities and initiatives to expand the use and effectiveness of real-world research in the medical device ecosystem. First, we have what we refer to as NEST 1.0. This is an evolution of NEST from designing and executing the pilot studies or test cases to actually offering our capabilities directly to our external stakeholders. NEST announced the launch of NEST 1.0 on June 30th of this year, opening our capabilities and research network to the medical device stakeholder community at large. Our next landmark initiative is active surveillance to monitor medical device safety. We've established our active surveillance task force, as well as our working groups for the IT cloud and surveillance methodology. And concurrently, since being recognized in 2019 by the FDA as a collaborative community, we're preparing our inaugural initiative focused on the adoption of unique device identifiers. As NEST continues to mature, our goal of offering real-world research to the larger medical device community is really quite simple: to deliver quality evidence by design. And we achieve this goal through three primary value drivers. First is our access to superior data, coupled with clinical and analytical expertise that enable us to identify the right type of real-world data for the type of study being performed within the medical device total product lifecycle. Our focus on real-world data with transparent and traceable sources leads to evidence that is fit for the objectives and goals of a particular study. And finally, our not-for-profit status as a community-governed organization allows us to foster that effective research. Next is our active surveillance initiative. The goal is to conduct timely software-based analysis on continually accrued real-world data during the post-market phase of the medical device lifecycle in order to identify potential safety signals. NEST received targeted funding from the FDA for active surveillance. As a part of our governance, we've established a task force, as well as 2 working groups. And in developing our infrastructure, we're building a cloud environment to enable effective active surveillance. We're analyzing the landscape of the existing tools that are available and currently being used for safety signal detection. And we're developing a roadmap for how active surveillance activities can be conducted. Finally, NEST was identified as an FDA Collaborative Community in 2019, for which now NEST plays a dual role. First, as a coordinating center for executing real-world evidence studies, and then also as a collaborative community to identify the needs that affect the broader medical device community and find appropriate solutions using this multi-stakeholder environment. Our first initiative is the UDI Adoption and Application Project. This will build upon research studies we've already performed, and as the roadmap for this project is being finalized, we will engage the broader community for public comment. Unique device identifiers affect all stakeholders, from manufacturers to health systems, to clinicians and patients, to payers and regulators. I'm extremely pleased that we have Mayo Clinic, Mercy, One Florida, and Yale New Haven Health from our research network as participating collaborators. Stay tuned for further information on this UDI project and the public webinar announcement that will be coming soon. Now that we've heard a little bit about our test cases and our lessons learned and our vision moving forward, we're moving into our panel discussion. Let's first start with Naomi Aronson. Naomi?
I am Executive Director for Clinical Evaluation, Innovation, and Policy at Blue Cross and Blue Shield Association. We serve the 38 independent Blue Cross and Blue Shield plans who cover collectively 1/3 of the population with evidence reviews, with analyses of the adequacy of evidence to support either determinations of medical necessity or investigational.
Thank you, Naomi. Next on our panel is Kathy Blake.
Sandy, thank you. I'm Kathy Blake, a cardiac electrophysiologist, and I'm Vice President for Healthcare Quality at the American Medical Association, and I'm a member of the NEST Governing Committee.
Thank you, Kathy. Diane Pickles. Diane, please introduce yourself.
So much. I am Diane Pickles. I work for the American Heart Association, where I am the program director for One Brave Idea, which is an $85 million adult coronary heart research initiative that is based in Boston. And I am also a member of the NEST Governing Committee.
Thank you so much. Jeffrey Shuren. Jeff, please.
Thank you. Hi, everyone. I'm the director of the Food and Drug Administration's Center for Devices and Radiological Health, and I, too, am a card-carrying member of the NEST Coordinating Center Governing Committee.
Thank you very much. I have a few
on the grounds of not being left out, I am also a member of the governing committee.
I have a few directed questions for each of the panelists before we get into our group discussion regarding the future. So Naomi, I will start with you and put you in the hot seat again. So certainly regulatory and reimbursement decisions are both critical to the introduction of a new device to the market. How would you characterize payers' considerations of real-world evidence in making coverage decisions?
So we don't think of real-world evidence as dichotomous, that there's real-world evidence over here and real trial evidence over here. First of all, real-world evidence actually covers a wide spectrum of potential methodologies, from electronic health data to pragmatic trials. What we are concerned about is the quality of the data and the suitability of the method for the question to which it's directed. Let me speak for a moment. The notion of fit for purpose data has been posed by the FDA and others. I think while real world evidence presents opportunities, it doesn't just grow from trees. You just can't, think of it as low hanging fruit, but it just doesn't fall to the ground that way. It needs curation, and it needs suitability for purpose. And I think one of the things that NEST has to offer is the confidence that you have curated data, that you've got fit for purpose data. That is kind of the number one base on which any kind of real world study has to stand. The other, of course, is the suitability to the question. Is this a question of efficacy? Is this a question of surveillance? Is this a question of capturing other groups that have not been included in the initial clinical trials, where I think real world evidence has real opportunity, because we cannot have clinical trials for every potential application. And without that additional information, health plans are often really stuck to the to the inclusion criteria of the original trials. And I think we recognize that there really are larger populations, but how do we identify them with suitability? So that is an example of one of the questions. But just in closing, I would emphasize again, real world evidence is one kind of evidence. It needs a solid fit for purpose platform of fit for purpose data, and the research methods and the study design have to be appropriate to the question being asked.
You bring up a really good point also that when we talk about real world data and real world evidence and its impact, that it's not dichotomous. You know, to quote Adrian Hernandez, who is the chair of our governing committee, since we're talking about that, we do need RCTs, and real world data and real world evidence can provide information throughout that spectrum, across that spectrum. And I think that's important. So thank you for bringing that up. Next, Kathy, from your perspective as a clinician, what do you see as being the benefits of real world evidence in supporting clinical decision making?
So I would first heartily endorse what Naomi has just said about the non-dichotomous relationship between evidence that is gathered, let's say, through a randomized clinical trial and evidence that is, quote, real world. Patients live in real worlds, so do clinicians. And the challenge oftentimes is that examination of the original or perhaps the first evidence that comes from a randomized trial and seeing the patient in front of you and saying, how closely does the individual I'm responsible for delivering care to match the patients who are in the randomized trial? We also know that randomized trials, when you look at the first sections of the article, frequently distill a large number of candidates down to a very small sample for a whole variety of reasons. So as a clinician, I'm looking for a larger sample that is sometimes only available through, let's say, post-market surveillance. I am looking often for a longitudinal follow-up that may exceed that of a randomized trial, especially if it is a medical device that someone may have for 10, 15, or more years. And I'm also looking for signal detection that is sometimes limited by the small number of people that are in an original trial. So as a clinician, I want to know about those signals, and I want a trusted source of signal evaluation, such as we will see with NEST.
Thank you. I think you bring up, again, very good points, Kathy, in ensuring that we have the longitudinal data that's also long-term to assess the device durability, that we're able to hopefully accomplish within our broad research network too, and get that data. Diane, from a patient and patient advocacy perspective, as NEST is expanding and expands its quality of evidence, what do you see as the benefits of real world evidence for patients?
Yeah, so obviously patients care deeply about shortening the time needed to get new technologies and treatments and medications into clinical practice. And I think real world evidence holds the promise of more robust, high quality sources of evidence to spur medical innovations and inform patient care. One particular important benefit I see is the ability to better stratify particular diseases. We know we can't treat patients with a one-size-fits-all approach. Yet it requires the ability to break apart a particular illness into subsets of disease and to understand which patients fall into those subsets, similar to what Kathy was talking about as a clinician. In order to do that, we need the ability to gather clinical data from a much broader patient population than those who are recruited for and studied in clinical trials. And we need to track them in real-world settings. And we can then look at different therapies to see where there's the greatest benefit for specific patients. So real-world evidence and precision medicine, I think, really go hand in hand. I would say that for patients who suffer from rare diseases, real-world evidence provides tremendous hope to spur more research and the development of new therapies, since we can decrease the time and costs of traditional clinical trials. I think another key benefit for patients lies in the role that real-world evidence can play in equity in research, since we can include a broad base of participants from a variety of healthcare settings, not just those in large academic centers where a particular clinical trial is being conducted. The ability to study much larger numbers of patients, including those not traditionally represented in research, such as women and people of color, is a tremendous benefit, I think, for patients. Another benefit I see is in shared registry data, which is really exciting for patients, particularly those living with rare diseases. I know that I am personally involved in the launching of a national registry for children and adults with single ventricle heart disease. And that registry will ultimately enable data sharing across all the institutions in the country that are treating these patients. That will enable the identification and dissemination of the most promising treatments and approaches, and really allow robust research to be conducted by any participating institution utilizing that data. And as the mother of a young adult with one of these single ventricle diseases, I can say that the registry gives me tremendous hope. Another benefit I see is the combination of digital wearable technology with clinical data, which I think is going to be incredibly powerful. You know, being able to track individuals in real time, in real life circumstances, provides data that's really rich and is truly measurable and quantifiable. And I think that those tools can dramatically enhance the quality of data over, our traditional physician check-in, where patients are simply asked, how are you feeling? What's been happening since the last appointment? How do you think that you're responding to a particular therapy? Obviously, patient recall is incomplete at best and unreliable at worst. So these tools, I think, really can provide much more validity. And I think these tools also can really empower patients to feel much more a part of their clinical care and their treatment decisions. And I would say last, but certainly not least, real-world evidence provides the ability to understand when particular therapies aren't working for patients, so we can abandon those ineffective treatments to save money and time, not just for the healthcare system, but for patients. And if we can, fast track awareness that a particular therapy isn't working for a patient, or even better yet, know in advance that a particular patient is unlikely to respond favorably to a particular therapy, that will certainly drive better outcomes for patients.
Thank you very much.
You're welcome.
And Jeff, as our chief regulator, would you provide insight on the regulatory perspective? Certainly we've gone through some test cases, and some of them have been completed, and we are continuing to make progress and completing more test cases as we go. How can these test cases help support safety alongside the faster technological innovations in the marketplace?
Well, I think as you noted in your presentation, those test cases can demonstrate the value proposition for the use of real-world evidence, for whether it be for safety, for innovation, but also it is a chance to inform us on how to connect the pipes for NEST and kick the tires, so that essentially we are flying the plane as we're building it, so that we can build it in ways that best meet the needs of the different constituencies in our medtech community. And so NEST can be built in a way that it becomes a vital component of a national safety net for patient safety, but also an engine to drive information to advance medical device innovation from the standpoint of being an efficient mechanism for generating information on the benefit risks of innovative technologies, but also informing us about where we have the need for innovation so we can develop the technologies we need or modify the technologies we have to best meet the needs of patients. And the test cases are a critical opportunity to build NEST to meet those needs.
Thank you. Kathy, if I could jump to you on, we hear a lot about value-based care lately within healthcare. How does the diversity of the data that's within the NEST research network provide the type of insight that can bring innovation to the delivery of healthcare?
So I want to go back first to the comment that I think you made, Sandy, which is to remind us who the end beneficiary is of everything we do, and that is the patient. So I think that it is then possible to talk about value from the standpoint of patient outcomes and outcomes that matter to patients, which may be aligned but different from the outcomes that matter to perhaps a regulator or the outcome that matters to a manufacturer or to a plan. I think we're all aligned, but it's the patient outcomes that are, to my mind, the bottom line. So if you then look at the opportunity within NEST and its data partners, you have data partners from all over the country, different types of organizations, and they serve different patient populations. So you're then able to use population health methods of analysis to say, these are the characteristics of the population that I care for. And I can ask a question of, in this large data lake or data set, data partners, can I construct a population that looks like mine? And having that match made, can I then anticipate the value for my population of patients of, say, one device compared to another? Because what we all want, ideally, is for the first device that a patient receives for treatment of a particular problem to be the best suited for them with the best outcomes. So that diversity of data sites, the ability to have comparative populations and then examine outcomes is, I think, one of the strengths that we are building for.
Thank you, Kathy. Naomi, certainly value-based care is of interest to payers as well. How do you foresee the use of real-world evidence that's generated by NEST on medical devices and technologies? How do you think the payers see that and will use that?
I think potentially real-world evidence can tell us really what is happening with those technologies that may not be really projected or predicted from the original trials. There may be more success than anticipated. There may be less success than anticipated. I think this does contribute to a value-based approach. I think it also can potentially contribute to somewhat more flexibility in looking at innovative technologies. That is, there's an inherent conservatism in the contractual basis for health plans. It's quite different than Medicare's reasonable and necessary criteria. And there really are not provisions for provisional coverage or coverage for evidence development. These are very hard to structure. And looking at the idea of takebacks is also a concern. A plan wants to be sure that once something is out there, it's going to stay out there. It is very much a dichotomous decision. And I think contractually it will remain the dichotomous decision. But I also think we know that everything we know about the technology is not true at a single point in time. So I would certainly advocate, though I don't believe it's necessarily a kind of an easy approach, to let the existence of ongoing surveillance and information, and in this case, surveillance would also have to be around the efficacy, not just the safety. And there would need to be clear FDA post-market surveillance landmarks that need to be met. With those kinds of provisions, it might provide somewhat more flexibility and speak to some of that conservatism in the coverage. I'm giving you my opinion. I am telling you that I would advocate for that approach, but I'm not saying that it will be easy to change existing contractual relationships and approaches.
Certainly you set challenges for us, and I think we might be up for the challenge, Naomi. But these are good things to consider as we envision NEST and how it can play a role for payers as we pivot for the future. Diane, I'd like to circle back to you, especially since you have, you know, a personal interest as well as the role that you play within AHA. But how do you see, especially, you know, NEST has several cardiology-based and cardiovascular test cases in particular, and how do you see these pilot cases advancing heart health?
So I think we need to start just briefly with the statistics to understand that we have a long way to go to prevent and treat cardiovascular disease, right? Heart disease is the #1 cause of death in the United States. Someone in this country has a stroke every 40 seconds, and nearly half of all US adults have some type of cardiovascular disease when you include individuals with high blood pressure, which can obviously lead to heart attack, heart failure, and stroke. And there are tremendous disparities, with African American adults being 40% more likely to have high blood pressure and being 20% more likely to die from heart disease than non-Hispanic whites. So I think it's clear that we still have a long way to go in effectively preventing and treating cardiovascular disease. And I think that each of the cardiovascular test cases hold the potential to help improve care in very significant ways. I'm particularly struck by the hypertension test case, given the incredible prevalence of hypertension, and most importantly, poorly controlled hypertension. Only 1 in 4 adults have their hypertension under control. So this test case seeks to characterize patients with uncontrolled blood pressure to understand their demographic and clinical characteristics and their medication treatment patterns. And then from there, determine which of those patients might benefit from a different treatment than typical, a minimally invasive catheter-based kidney intervention. I think being able to identify subsets of patients and what makes them unique could really enable tailored approaches to more effectively treating this leading cause of heart attack and strokes. Looking ahead, that research might fast-track best approaches to individual patients, which would save time and money and lives. I'm also very excited about the test case exploring wearable technology as a source of real-world data and real-world evidence for cardiovascular disease. While there's definitely some inherent challenges in utilizing something like our Apple Watch to detect arrhythmias, such as false negatives or false positives, it's clearly technology with high potential, and I think with a great deal of patient interest. The data gathered through digital wearables, whether it's an Apple Watch or a Fitbit or a Whoop, which I've just learned about, has the potential for both diagnostics and as a prevention and health maintenance tool. So I think that that technology, which has advanced rapidly, holds a lot of promise, but we need to play some catch up in understanding viable and appropriate clinical applications, which is what the test case is really addressing. And it's also, obviously for me, it was very exciting to see the test case around congenital heart disease and heart stents. As you know, formal regulatory approval for devices that are used in congenital heart disease is rare, and the majority are used off-label after adult approval. And that's really problematic since children are not just little adults, and congenital heart disease is a very different disease from adult coronary heart disease. So I think the ability to track usage of these devices and their effectiveness in children with congenital heart disease has the potential to have tremendous impact on how these kids are treated, which will advance both their quality of life and their longevity.
Well, I have to say, I have not heard of WHOOP, so this is my introduction right here. Thank you very much. At NEST, we learn something new every day. And Jeff, you know, I think you have been hearing part of the responses from the panelists also include safety, you know, learning more about safety and safety signals. How does FDA foresee the role of active surveillance as we continue to mature the initiative?
Active surveillance will be the next step in the evolution of efforts to assure patient safety. And we think it's going to be an essential component of a more robust safety net for patients. Today, you know, traditionally, we have had to rely on either post-market studies to understand new safety concerns. Of course, those studies can take a long time to be conducted, and we may miss things because of their inherent design. Or we're dependent upon passive surveillance. A human being, typically a clinician, can identify that some problem occurred that they think is associated with a device, and they take the time to report it to the manufacturer, the FDA. And as a result, by the time we identify a safety concern, many patients may have been exposed. With active surveillance and taking the advantage of more modern technologies to, if you will, sift through large data sets, looking for potential safety concerns, we can identify problems more quickly, so fewer patients exposed, and then the opportunity to address those problems much more expeditiously. So fewer patients harmed, and greater opportunity to protect the technology too, and not lose consumer confidence in it. As we look to the future, active surveillance can also help us in our efforts to strike the right balance in pre-market and post-market data collection. Increasingly, we deal with technologies that may be better informed from understanding its performance in real-world use, but we can't responsibly put her on the market until we have not only high confidence in the performance of that technology, but also confidence that if issues or problems arise, that we're going to be able to detect it in a timely manner. And the availability of a robust active surveillance capability would allow us to introduce important technologies responsibly, potentially at an earlier point into the marketplace. Again, because we would have that more robust safety net in place.
Thank you very much. So we have a lot to accomplish in our active surveillance initiative. And I think having the FDA and CDRH as a partner as we help develop that, I think will be critical as NEST continues to move forward with this initiative and the impact that it can have within the ecosystem. I'd like to pivot to more of a group discussion now. And what future impacts do you see from your perspectives of real-world data and real-world evidence in 5 or 10 years' time?
Well, Sandy, I'll take a crack at starting. You know, I think that patient awareness and understanding of real world data is going to increase dramatically. And I believe that that will in turn may drive the utilization of real world data in research, because patient demand for it will increase. You know, I gave that example earlier of the national registry that we're building around single ventricle heart disease. And parents of kids with these diseases and the young adult survivors of these diseases are clamoring for the registry. We've been hearing from physicians that their patients are already asking if they participate in the registry, and we haven't even launched it yet. So, you know, as rare disease patients who face significant comorbidities and shortened life expectancy, this patient population understands the potential for finding better treatments and approaches through this collaborative data sharing. I think another example of growing interest is the awareness among patients is the way we've seen the general population, you know, signing up to participate in some real world data research, including digital wearable health studies, you know, by Apple and Fitbit and others, as well as online registries such as, you know, Verily's Project Baseline and the AHA's Research Goes Red. So as I look ahead, I see tremendous potential for more patient awareness, increased patient engagement. And I think the ability to stratify diseases, as I spoke to earlier, is really going to spur innovations in targeted therapies. So, you know, I think the future is actually very bright for precision medicine and advances in treating all diseases, including cardiovascular disease. And that's a lot of what I see looking ahead.
So I'd like to suggest that what it does is it will help us build our understanding of the body of evidence. Often we're talking about studies, this pivotal trial, that cohort follow-up, that particular safety signal. But in the end, decisions need to be made by understanding in breadth, you know, what are the dimensions of the body of evidence around this technology. But to say this technology is really just a kind of a partial view. It's this technology, these patients, these settings, and these particular outcome preferences or focuses. And so I think real world evidence has the potential to really broaden our understanding of a body of evidence and give us a much more subtle and detailed understanding of what that body is and the various questions within that body that it addresses.
I might add to it, and I do want to go back to the thought that Diane shared with us, which is the really the participation of individuals, people who are not always patients, and the participation of overly busy clinicians in evidence generation. And I do think that we will start to see in that 5 to 10 year horizon greater participation, because if you are submitting data from one of your wearables, you have a sense of ownership and of agency with respect to that device. I think also that for clinicians, if they are able to see the evidence and the analyses of that evidence more quickly and able to see themselves as direct contributors to that learning health system, then I think that there are great benefits to be reaped. So that we'll no longer have that demarcation or that chasm between the individuals who are caring for patients full-time and the researchers. I think that we can cross that research chasm, so to speak.
So I will play cleanup again. So I kind of echo the sentiment of the importance of the generation of evidence and really of knowledge, and to be able to generate knowledge that is more informative, more timely, and also more efficient. And from the regulatory side of the house, the challenge we face in today's world is we've got a regulatory paradigm that's over 40 years old, and it's just not fit for purpose for a lot of today's technologies, and technologies that are innovating at a significantly more rapid rate than we ever saw before. And, for example, a lot of the digital health technologies. And something we've learned from our experience with the COVID-19 pandemic is the value of flexibility in approach, trying to have that balance of putting out critically important technologies that the public needs, doing it responsibly, but trying to put that out in a timely manner. And we need regulatory paradigms that advance that objective. But to get there, real world evidence and through mechanisms like NEST, if we're able to build what we've all been striving for years, a true learning healthcare model, then we can have different regulatory approaches that better align with the innovation cycles we're seeing in modern technologies, but again, doing it in a way that provides the information necessary for healthcare professionals and for patients to make the right decisions and to inform developers on the kind of innovations and technologies where they should focus their attention. And so I see real-world evidence as really at the crux of modernizing how we approach technologies and how we learn in the healthcare community.
I think that's excellent discussion. We have several other initiatives that we touched upon, like active surveillance and the collaborative community and UDI adoption. And I'm wondering in our final minutes together, if the group can speak to ways in which these projects could bring value to our medical device environment overall and to the various stakeholder groups in particular.
So I'd like to touch on collaborative communities, which is a strategic priority for CDRH, and it's really a way of doing business different for government because we're typically taking on the role of leading efforts, being in the driver's seat. And the collaborative community is much more about the community solving its own problems and trying to achieve shared outcomes, and government participates as a member of that community. And, NEST was always envisioned as being that of, by, and for the community. And that is designed to meet the needs of the community, patients being at the top. But the best way to do that is it's the community that's actively engaged in the design and in the use of NEST. And the collaborative community to us is the best way to have that voice from all the key constituencies in the community participating. And that's why we're so excited by collaborative communities generally and in particular in the setting of NEST.
Well, I'll chime in and add my thoughts briefly to say, on that note around the collaborative community, I would say, no doubt, patients need more collaboration and less competition in healthcare in general and in scientific research. So I think the collaborative community offers really an invaluable opportunity to advance care for patients in big ways. I'll say just briefly, I think the UDI initiative is critically important for cardiovascular patients, for all patients, but cardiovascular patients for sure, whether we're talking about cardiac stents or heart valves or ventricular assist devices, both in terms of patient safety and treatment efficacy. Regarding the active surveillance initiative, clearly there's great potential to improve patient safety and health outcomes, as Jeff spoke to, when we move from passive surveillance to active surveillance to detect safety signals. As medical innovation is moving forward at really an unprecedented pace, I think this work is absolutely essential for patient safety. I'd give the example of a study that was led by the University of California, San Francisco, and funded by the NIH, which examined deaths of individuals who had implantable cardiac defibrillators by looking at their autopsy reports. And they found a substantial number of these individuals died from cardiac arrhythmias, which obviously their implantable devices were designed to prevent. So in other words, they found device malfunctions which were previously unknown and unreported. NEST leadership and collaborative approach in this arena, I think, holds great potential to advance care for cardiovascular patients. so that patients aren't relying upon voluntary, unverified, and incomplete reporting of adverse events.
I'm going to seize on the idea of collaboration. And one of the things that has been so important and hard to achieve is collaboration and the availability of data. That is, we have so much data that remains proprietary, and we have, in many cases, kind of a blind man in the elephant situation, with people having pieces of the knowledge. And so I just want to speak highly of efforts that will bring us to more collaborative approaches to data. I know that there are always competitive issues, but ultimately, I think we've got to have full knowledge to make progress. I will, quote that famous quote. It was Newton who said, "I've seen farther because I've stood on the shoulders of giants." We have to make shoulders to make more giants, to see farther.